Good afternoon, everyone, and thank you for the opportunity to moderate this important discussion. Thank you, Dr. Gross and Dr. Yamaguchi, for joining me for this panel. And Dr. Harrison, you covered a tremendous amount of information and ground in your brief opening remarks. We have a lot to digest on this topic. So I would like to start a little bit where you left off. What caught my attention in your remarks was that the percentage of telehealth claims appears to have stabilized, but the investment continues to increase. And I have two questions for the panelists related to that. First, do we feel that this level of utilization that we continue to see is fueled by some of the temporary regulatory and reimbursement changes that we have been given during the pandemic, and by the lower out-of-pocket costs for the members who utilize telehealth? Or do you think we actually, given how much time has passed, unfortunately, established a new baseline for telehealth utilization from which we will continue to grow? David, maybe you can get us started. What do you think? And then we'll turn it over to Dr. Gross and Dr. Yamaguchi.
Oh, sure, definitely. Well, it's a great question, Magda. And everyone is waiting with bated breath to see what will happen. And, my own take in discussions with folks who have more public policy experience suggests that, a lot of the relaxations we see and a lot of the reimbursement changes we see not become permanent. That, it's kind of like things, uncertainty tends to slow things down. But I think that even if the conclusion is that some temporary changes are rolled back, once we know what's going to happen, then people can really build out the reimbursement models and do the planning. And I'll turn it over to folks who know this much better than myself.
Yeah, I'd be happy to address that. I think that the reduction in barriers, number one, to the implementation of broad telehealth strategies is part of the reason that we see this new normal, if you will. And I also think that we need to be careful about terms. And, when I ran into this, as I was looking at the information that David had pulled together about surveys that indicated telehealth usage or telemedicine usage, and I was comparing that to the all claims database that looks at telehealth claims. And if you look just at claims, there are only about 13 million individuals used telemedicine last year. Now, that you look at the two and they don't make any sense. Well, it turns out that a lot of the telehealth that's provided doesn't generate a claim. They're rolled into the fully insured product, and a discrete claim is not part of the process. The other point that I think is worth making is that I think we need to differentiate telehealth from digitally enabled care. And that's really what we're talking about going forward. Listening to David's comments about all of the tools that are available on the VertaHealth site, for example. And how do I know this? I'm pre-diabetic, and I thought, well, if I'm going to be advocating for this program for our payer, then I ought to try it. And the number of tools that focus on the psychology of human behavior is enormous. I mean, there's data there on managing stress. There's positive reinforcement because you're able to track your own results over time and you get that immediate feedback. And there's a relationship that develops between the patient, in this case me, and the coach over time. It's a longitudinal relationship, and that's really important in human psychology. The future of telehealth, I think, depends on clearly defining terms so that we're actually measuring what we seek to measure, number one. And number two, I do believe that reducing those barriers will help. And the final point that I would make is the closer we get to a prepaid or capitated method of reimbursement, changing the incentives, the closer we're going to get to adoption of tools like digitally enabled health that dramatically improve efficiency.
Yeah, so I have two different perspectives of this. One, I'm the chief medical officer for Centene, a very large payer. But the other thing is I'm actually still a practicing orthopedic surgeon. I saw a clinic full of patients today, and I operate every week. So I actually have the provider perspective. And in this case, I think the provider perspective is actually more informative about what David was talking about with the spike from COVID and then the drop and then the plateau that's higher than before. What Dr. Groves was talking about with barriers, the biggest barrier that I think that is present is not economic. It's not about reimbursements, et cetera, processing claims, et cetera. It's actually time. And so if you're a clinician seeing a patient in an office, the barrier to seeing the next patient is walking 3 steps from one room to the next room and then seeing your next patient, flipping on your EMR and you're ready to go, as opposed to a whole lot of things that are going on with whatever you want to use, whatever medium you use, Zoom, connecting each time, often with an elderly patient that has some discomfort with it. You got about 15 minutes to make sure they got their video set, all this other stuff. And now you're spending 45 minutes on a patient that you may have spent 5 minutes on a post-op check. And you know, for many physicians, if you would say, what is their most valuable commodity? They'll immediately say it's time. And so until we have EMRs and other systems that really facilitate telemedicine to a dramatically better level, I think that's going to be the limiting factor for that type of telemedicine. Now, what we really have seen a lot of is telemedicine for specific specialized initiatives like VERTA for pre-diabetes and other specialty companies that use apps and other digital means to really motivate, use behavioral economic means to get better patient adherence, et cetera. And I think that telemedicine is exploding in that area and is a great avenue for that. I think when we get to some of the other points here, I'll have some more to discuss about those issues. But the one thing that we've seen sustaining for our patients, and this is not something I have the provider hat for on because this is behavioral health, which is probably about as far away from orthopedic surgery as it gets. But behavioral health seems to be sustaining. It went up as a result of COVID and it's staying up because I think that those barriers of time, connection, all that stuff is much less an issue to the 1 hour general appointments that you see in behavioral health. And it is just it's something that really most patients, especially younger generation, but more and more older generation, getting comfortable with that. And so that I think may be kind of the model, what might happen on the physical health side, but we haven't seen it yet. I would say, again, those are the two main barriers. The sustaining is really on the behavioral health side, the opportunities on the physical health side. There's already a lot of opportunity that's being realized on the specialty side.
Thank you, Dr. Yamaguchi. And you've touched on this a little bit, using mental health as a perfect example of where the greatest untapped opportunity was and where digitally enabled care, and I'll try to use it consistently now, Dr. Groves, since you introduced that term, where virtual care was able to close some of those gaps. As you look at the industry today, and as you have some visibility to where this investment, increasing investment that David talked about is going, do you think the money is going where the greatest opportunity continues to be? Or is it kind of following the leader maybe a little bit? What are the greatest untapped opportunities here? Dr. Yamaguchi, would you like to continue?
Oh, okay. I thought you were asking Dr. Groves. Okay. Yeah, you know, I'm not sure that the investments are really focused appropriately. In the specialty area, yes, a lot of intriguing companies like VERTA that seem to be having a lot of success in a relatively narrow area of focus. Diabetes, a narrow area with tremendous impact, but if you're talking about general physical medicine or general behavioral health, what I would like to see more is looking at things that increase the value of the means, the channel, telemedicine, that is, rather than actually enabling more of it and more volume of it. So in other words, there is some push towards clinical decision support, for instance, but I think that that's still a huge opportunity, using vast amounts of data to really push algorithms to really more standardized care. United States care for most things in physical health really depends on, number one, the biggest impact is geography. Where are you getting your care? It probably influences what kind of care you get more than anything else. But it really should be all about the disease process of the person. And these things can be really standardized quite a bit through algorithms based on millions and millions of doctor experiences with people, because we have the machine learning capabilities now, we have the data capabilities now, but we really haven't gotten to that situation where we're using it for clinical decision support. The other part that is complementary to that is patient decision support, because it's a two-way street, that the same information in a different packaging helps patients decide among 2 or 3 viable options what may be the best for their specific situation, and also packaging that data so that it goes with the patient, with the member, and there's less proprietary interest in protecting data between health plan and other health plans and stuff like that. I think these are the real opportunities for digital medicine in the future. The main thing that for me is driving the cost of medicine is, as opposed to cost of computers, for instance, is that we cannot scale a fundamental anchor in medicine, which is the patient-doctor relationship. So I always talk about, as a surgeon, the number of people I see in clinic today is very similar to the number of people that a doctor saw in clinic 100 years ago. The number of patients that I operate on an OR day is maybe at most 1.5, but maybe on a really efficient day twice as good as it was 100 years ago. But it's not 100 times better, like it would be a computer be, 100 times faster than 2 years ago, right? And so we're not scaling that doctor-patient relationship, and clinical decision support tools and other things through telemedicine are perhaps that opportunity. But as David talked about, that there's that anchor of that basic doctor-patient relationship that we haven't been able to really get past yet, and that's whatever the resources are to get there would probably be just mind-blowing in terms of what it could do to medicine.
Dr. Gross, back to on where the investment should be going and where the greatest untapped opportunity is. I want to give you a chance to continue to contribute.
Yeah, I would just like to echo Dr. Yamaguchi's points in that knowledge management really is a great frontier for digitally enabled care. I think that the concept that Virta has put forward of continuous remote care, frankly, in my view, that's the biggest opportunity. And I can see that being part of a standard physician practice. I'm not talking about replacing the in-person care that's necessary for deep relationship establishment, and certainly remote surgery. The robots aren't that good yet, although maybe they are. I don't know. Maybe we just haven't made that leap. I could ask Dr. Yamaguchi that question. But continuous remote care to me means that I, as a patient, have access to information from experts in real time, day by day. So I'm not waiting for 2 months to come back or 3 months to come back and see my physician before I can ask a question like, what am I supposed to do in this situation? How about this situation? Or I noticed this or that about how I feel. Being able to get that information immediately. And I think patients would love to be able to get that from their primary care physician or from their surgeon, to be able in the recovery period. And obviously it might not be the surgeon doing it any more than it is when I interact with Virta. It's a very skilled and knowledgeable health coach who understands relationships and does that job very well. Continuous remote care can be applied to so many aspects of medicine. And I see this as an enhancement. You know, I think back to when we rolled out tele-ICU at Banner Health back in 2005 now, so a while ago. The idea was not to replace the intensivist, obviously. The idea was to enhance the skills of the intensivist through knowledge management, having an algorithm that looked for adverse trends before they could become adverse outcomes. So that enhancement, we found, reduced cost via dramatic reductions in length of stay, about 25+%. And it also improved quality by about the same amount, about 25 to 30%. This is compared to the Apache norms. So, it's not an either or in my mind. It's how do we use it to enhance the services that we already provide and to make them more efficient? And for that, we'll need a change in incentives.
I just quickly wanted to add, Dr. Groves talked a little bit about continuous remote care from the, patient perspective and having this immediate access to information. And I just want to say as well, with, again, at the risk, don't want to make this an ad for Virta, but, from the physician perspective, it is a lot of fun as well. So I, like Ken, I had clinic this morning at Mass General. I was running around seeing patients rushed over here. And, I saw a handful of patients there. When I, work with patients at Virta, they are all logging their information. For them, it's diabetes related information, their blood sugars and all this stuff. But you can also imagine it with congestive heart failure and people logging their, their weights and O2 sats and other measures. And instead of interaction being driven by an appointment schedule, I see them because I last saw them 3 months ago. It's driven by the system bringing in all this data and bringing to the top of attention those patients who are most likely to need a medical intervention. And in this way, one can round virtually on hundreds of patients a day instead of just with microtransactions, instead of only seeing, 8 or 15 or a busy day, 20 patients in 15 or 30-minute chunks.
Can I just add one other perspective? Unfortunately, I had a perspective from the patient side, navigating the system for my parents last year during COVID. And the other thing that digital and telehealth does is it's a powerful tool that helps to deliver care, but it's also adds more complexity to an already complex situation. And I just was overwhelmed thinking, okay, I'm relatively knowledgeable about healthcare. I'm having a hard time navigating this landscape. How do people who are not so experienced and knowledgeable navigate this? And then I got introduced to certain companies like I'll say in this forum, for instance, a company called Pager that really works like a digital front door. So you come in, you talk to. It's more like it's like a concierge. They'll try to figure out, okay, your primary problem is this. We'll connect, use your primary problems related to pre-diabetes. We'll connect you over to Virta and blah blah blah. Or if you have a emergent issue, they're going to connect you to maybe a triage situation like Teladoc or directly to the emergency room. And they actually will walk you right through from the front door all the way through to the back door if needed. And I was like, oh, geez, this is what's really needed too if you're going to really enhance digital capabilities, because it is complicated. It's really, really complicated. All the options that are available for any given member or patient it's mind blowing. And the lower the socioeconomic situation is, the harder that gets.
You offered so many great examples of importance of how data can be used differently, how integrated data sets can or should be used differently. And I think we're just living in a very dynamic time where everything is changing. And to the point Dr. Groves made earlier, if we're not trying to recreate the same thing that we already have just through a different platform, it's a fundamental time of change for providers, for patients. And it should also be a time for change for health plans. And I'm wondering, since you both represent health plans, in addition to being clinicians, I'm wondering if you could speak to what role health plans see themselves playing in promoting the greater and the more appropriate and more effective use of digitally enabled care.
So Centene will promote these things all through the traditional means of reaching out through different media sources and stuff to make sure our members are aware of these resources, that they're available, that they are low cost, in the last year and a half, free essentially, and what are the capabilities. But our partnership goes further than that and can go even further than that. One of the main areas of opportunity for health plans would be helping in development, partnering, because we have so much knowledge of the member. For instance, Centene focuses on the lower income portions of our populations. They have very specific digital issues as opposed to a standard private carrier population. So, we've partnered with multiple large telehealth companies to help develop products specific to the language and cultural issues that are seen in our population. We also have extraordinary amounts of data that can help develop some of the chat and AI robots interactions with patients and help them develop with these things and algorithm protocols. But the other part about this is we are piloting virtual health plan initiatives too. With even full risk involved, to try to really see what opportunities may be there, and probably the biggest opportunity is in primary care, where there's just a shortage and you need to scale that, and a shockingly large population of even elderly people in our country don't access primary care regularly. I learned in business school that $1 you save before a problem becomes $100 after the problem. So I think you can multiply that in medicine, and so these are some digital opportunities that are substantial that health plans can partner with.
How about Aetna?
Yeah, I would echo that, and Banner Aetna is an example of a big step forward in aligning incentives, and what the company is a partnership between Banner Health, about a $10 billion integrated delivery system based in Phoenix, and of course Aetna, that everybody is aware of. And our parents, if you will, are 50-50 owners in this. So the incentives from the start are aligned for us to be innovative and to strategize how we are going to change the experience for patients and providers in our market, which is primarily Arizona, though we cover folks all over the country, obviously for businesses that are larger than the Arizona footprint.
Mm-hmm.
Some of the things that we're doing is we're on the lookout for innovation in healthcare. One of the reasons that Virta came on my radar was because about 12 months before the pandemic, we started thinking about, okay, what is disease management and what should we be focused on? And we came up with two areas. One is metabolic syndrome, diabetes, and the other is behavioral health. We saw those as areas that were underserved and that would require us to to get creative to really do a good job of taking care of those folks. And so those two initiatives led us to look at what's available in diabetes, look at what's available in behavioral health. Both of them, it turns out, are very amenable to the digital strategy that we've employed. The other thing that I would say about what health plans can do is we can also try to make it easier for our members and our docs to do business with us. We're trying to cut through the complexity of prior authorization, for example, and make that more of a knowledge management issue. Again, if the doc on the front end has the information they need, then we shouldn't have the delays and the administrative burden of prior authorization driving the effort. The final thing that I want to say is we need to start paying attention to what major brands have been paying attention to for ages, and that's psychographic profiling of members. Why is that important? Because only when we understand what motivates behaviors can we begin to change it. Everybody has a great analytics strategy. The question is, it's not enough to know what's going on. How do I actually change a patient's behavior? And that's where companies like Trilliant, with the databases that they leverage that include healthcare databases, can actually provide some guidance on future demand and patient behaviors and allow us to intervene in ways that make sense for the population that we're addressing. It's cultural competence, but it's beyond that to individual motivations.
Thank you. And you touched a little bit on supporting providers, or at least changing the way, helping them increase some of the efficiency in their workflow. And we actually have a question from the audience about any breakthroughs you might be seeing in optimizing workflow efficiency of the providers. Any breakthroughs that are either tied to technology or just to how they perform the work?
I'm not sure I would yet characterize what we're doing as a breakthrough. As Dr. Yamaguchi said, it's highly complex. I mean, when I moved from the delivery side, where I spent a dozen years in leadership roles, over to the payer side, I was astounded that there were several more layers of complexity that I did not appreciate before I got involved in it. So it's going to take us some time to get there. But what if we had real-time prior authorization approval? In other words, in the moment, while the patient's sitting there, what if it were easy for patients to see what services are available to them, so that they knew that Virta was available for free, or they knew that a free telemedicine service like 98.6 was available to them. A lot of times people sign up for their health plan at the beginning of the year, and then after that, they forget about it. So they have no idea that there are tons of resources that they don't take advantage of because they don't know they're there. So we're working on that aspect, to have a place where they can navigate easily to all of the resources that are available by individual, by plan, et cetera. So those are the kinds of things that we're working on. We don't have a breakthrough yet, but we hope to, within the next 2 to 3 years, be able to solve some of those major problems.
I couldn't agree more with what Dr. Groves said. I'd say the first thing that would be helpful to the payer side, providing or facilitating things that will create better efficiencies on the provider side, is actually financial incentives and partnerships, so shared risk arrangements. So once you have shared risk arrangements, I think those type of things flow pretty quickly. And the greatest area of opportunity is actually in, as Dr. Groves talked about, is prior authorizations. If you ask providers what they hate most about payers, they'll say prior authorizations. If you ask payers what they hate most about the business of healthcare management, they'll say prior authorizations. Both sides hate prior authorizations with a passion. It takes ginormous staffing and IT resources to execute on both sides of the equation, and it's currently used to govern the process. Once you turn it into a shared risk or partnership situation, it now could become something where it is a knowledge-based tool, like Dr. Groves talks about, and it can be used to improve the value of medicine. It can be used to improve the quality of what we do and the standardization of what we do. So it starts with a shared risk, and then I think there'll be rapid developments in that area. Currently the doubling time for medical information is staggering. It's like every 4 or 5 years. We're really getting to the point that doctors will not be able to stay up with all the current information, and it will require things like artificial intelligence, machine learning, large amounts of data to really get better standardized care for people. And payers have the resources and the information to make that possible, but providers need to be financially incentivized to be able to use that too. And I agree with Dr. Groves that in time, the future's prior authorizations will be not a governance tool. It'll be embraced by providers as a way to make sure they take the best care of patients, because they'll be financially rewarded for doing so.
And I think we've seen early in the pandemic some of the data that supports the last point you were making there, that in value-based arrangements, the virtual care adoption was faster. And those models were more flexible to adapt to the new normal that we were witnessing. There's another question from the audience, which I think is interesting, especially when we see our health resources really challenged by another COVID surge, and it ties to the earlier conversation about the importance of continuous relationship and longitudinal relationship with virtual health provider. Are there enough providers and nurses simply within the system? Is there enough capacity within the system to create that model of continuous longitudinal care?
I'd say in the primary care space, the data would say no. There's not enough primary care. It's actually a worldwide phenomenon, not just the United States, to really make sure that we're doing all we can in preventative medicine and having the appropriate gatekeeping and referral patterns there. The actual shortage of primary care is worse than it seems, because a lot of people are content not to see a primary care physician because they don't actually know better that they really should be. So it's not part of the culture as well. But yeah, I do think that there is a significant deficit there, and I would say from our difficulties in hiring nurses, there needs to be more nurses too.
I agree 100% from the provider side. And I think this loops back very nicely to the previous discussion about efficiency in healthcare. Because if our physicians and nurses could be more efficient, then we would have enough people. And one of the key concepts is that in medicine, there is a tremendous noise to signal ratio. In any given clinical encounter, there are some super complex ones, but usually there are just a handful of decisions that need to be made. There is also the work of establishing a relationship of trust, but that can develop over many, many microtransactions. And that's one of the ideas, especially what Dr. Yamaguchi said about clinical decision support and continuous remote care. If we can turn our physicians and nurses from feeling like they're checkout clerks at the local Target, just one after the next, and instead have them be like, men and women manning a mission control center and having these clinical questions presented to them as they need to be solved, addressing them and going to the next patient, this actually multiplies the efficacy and impact of each individual clinician.
And let me echo that and give an example again from our experience with tele-ICU at Banner Health. First of all, it was a great thing to have in place, by the way, during the pandemic, because so much could be done for patients without exposing nurses and without occupying the time necessary for them to come in and out of the room. That doesn't mean that folks don't need to go into the room. Of course they do, but that can be a planned activity rather than a necessitated activity because the other resources aren't there to leverage, i.e. tele-ICU. But what we did to actually get our doctors to acknowledge that tele-ICU was a good idea is we framed it like this. Look, let electronic systems take care of the rote stuff that has to be done, the stuff that we need every day that we shouldn't miss. Let the electronics take care of that so that physicians can focus on what they're best at. And what they're best at is that pattern recognition, that understanding, the patient, the connection to the patient, that relationship with the patient, their family, whoever. And if physicians have time to do that, I have no doubt that they can have a much broader influence on patient behaviors. What we haven't yet mastered is the use of technology to enable physician activity. A great example of that's the EMR, right? I mean, it has taken up so much more time for clerical activities that physicians really don't need to do. Let AI and voice recognition and natural language processing, let's have an electronic scribe in the room that can put out that note. And then the physician is in the position that they want to be in. They're looking at the science, they're looking at behavioral science, and they're trying to figure out, how do I help this patient get better? That's where we need to get, and that's how we ought to focus our efforts around technology.
Creating efficiencies will get us there. You brought it back a little bit to patients, and that's where I would like to go next. There was a lot of hope that virtual care delivery, telehealth, will bring healthcare closer to some of the most vulnerable populations, or maybe will help us reach some of the patients who, as Dr. Yamaguchi said, that were not engaged with the system due to various barriers to access. I'm wondering if you're seeing whether this stronger transition to telehealth is helping those most vulnerable. And maybe, David, I can start with you with some data insights that you may have on this, and then ask others to comment.
Sure, definitely, Magda. And I'm really encouraged. Health equity is an integral and indispensable part of healthcare quality. So the best data source that I could find was that household pulse survey from the U.S. Census Bureau. But looking at, if we look at, past 4 weeks utilization nationwide, it's around 20%. Very wide state to state variation, as Dr. Yamaguchi said, geography is important. But we actually saw the highest use in folks with no high school diploma, 24%. We saw higher use in gay, lesbian, and bisexual patients, 24 to 25%, than straight patients, 19. Higher use by people with disability, perhaps not surprising, 31%, than no disability, 18. Higher utilization with non-Hispanic Black, 24%, or non-Hispanic Latino, 22%, versus non-Hispanic White, 18%. So yes, this is encouraging evidence to suggest that telemedicine may be helping to improve access for more vulnerable populations. But of course, there always is the caveat that utilization does not automatically equal better quality or better outcomes.
There's another piece to this that we haven't talked about yet, and that is that if you look at broadband speeds in this country, they are the worst in the developed world. If you look at coverage, anybody that's done any traveling knows that there are huge blank spots And people live in those blank spots. And so they're not going to have great access. A satellite connection is just way too much of a hassle. So broadband infrastructure is a big deal, and we need to focus on that. We also need to focus on affordability. It's great to have a telemedicine link, but if you can't afford a plan that allows you to use it, or you can't afford a smartphone that allows you to use it, then it's not going to help. And there will always be some populations that are in that category. We want to minimize that, obviously. And that, access is a big deal. Having the broadband infrastructure to allow that any place in the country where people live, and having affordability so that folks that need that actually can afford to make the investments to have it.
Our experience is very similar to what the numbers Dr. Harrison quoted. About 25% of those members that have utilized services have tried some aspect of telemedicine. So even among our members, which are, again, represent the more poor in the United States, there's been relatively high utilization rates. The issues there are conflicting. There's certainly significant issues about being able to afford broadband access and having the necessary hardware to use it, even if you can access it. Those for the large part can get trumped by the ability to access medical care when you otherwise wouldn't. Some of our members have to take 3 buses and go, take time off of work that they absolutely cannot afford to do to get there, and then maybe come back at a time when it may be getting closer to sundown and they have safety concerns and stuff. Things that all of us really cannot relate with. I mean, just daily life stresses that we can relate with that really, really come into as kind of a barrier to utilizing. And then the other part of the equation is the rural populations, and it was what Dr. Groves was talking about. Their issue tends to be more in the access area to access, but there are emerging means to access them with 5G LTE. Actually, there's a safety net network coming out, etc. I think that the access to high speed is not the main issue. The main issue is more affordability, and that really should not be an issue because the cost of access to this will be trumped by the medical savings. Absolutely swamped by it. The ROI would be wonderful on that. So you figure we ought to be able to cross that barrier very quickly. Education's another thing that's really getting less of an issue now. The poorer populations tend to be less educated and comfortable with some of the technological possibilities of these things. But the other flip side of that is that vendors have to be very, very empathetic to those issues. We will get to vendors coming in all the time with great ideas, great products, and I'll say, well, have you made all of the communications 3rd grade equivalent or less? Because that's our requirement. And what? We didn't know you had to do that, and stuff like so. There certainly is some opportunities and empathy for this population.
Thank you. And to close this panel, with 4 minutes remaining, I have to make sure we touch on what was the title of this presentation, which is how do we bring care that's now routinely delivered in clinics or hospitals home? So if you go past the current wonderful noise of the level of change we're seeing and some of the current barriers that we're seeking to overcome and look further into the future, what do you think will be fundamentally moving to home? And do you think it will just require virtual care delivery, or will it have to be supported by growth at home services and traveling nurses, etc.? Dr. Groves?
Yeah, I think that it will be both. We've seen this happen already. I was thinking back to when I was in training, and one of the first publications that I participated in was a variation in length of stay for elective bronchoscopy. Now, that sounds laughable today because nobody is admitted for elective bronchoscopy. So we've seen that trend continue. I'm thinking of my colleagues at Optum who have urgent care centers actually that will take care of routine pulmonary embolus. They look at them overnight. These are 24-hour urgent cares, and then they go home instead of being admitted to the hospital. You think of things that have typically been, it's not a hospital, but it's certainly a prescribed area like dialysis. Well, CVS and one of our partners now at the acquisition of Aetna is looking at home dialysis. It's been demonstrated that that can be done safely. It's far less expensive. It's a satisfier in terms of the individuals that are responsible for the dialysis. I think that there are a number of, and by the way, Mayo, Banner, many other systems are looking at, I'll put it in quotation marks because it means different things to different people, but hospital at home. And once we get to the point where we can truly do continuous remote care, a lot of our angst at allowing patients to go home goes away because we can monitor those critical aspects of their care. The other thing that I think is going to revolutionize this is the technology of photoplethysmography, or the Humble pulse ox. There are now algorithms that allow via a smartphone camera, comprehensive vital sign measurements. Blood pressure is one that's the last one to come online, but it's clearly within reach. And so we'll be able to get a full set of vital signs without sending a cuff home, without sending any other equipment home except with the smartphone. And as long as you got the broadband and you've got the access to that, I think that's going to really change a lot about what we do. So continuous remote monitoring and the advances in technology and photoplethysmography are going to take us a long way towards getting folks out of the hospital. Predicted demand for hospital beds, in spite of the increasing disease burden, by the way, has been flat. And it's predicted to continue to be flat. And one of the reasons is because we're learning how to move a lot of those issues out of the hospital, which is a dangerous place to be. Hospital, not home.
Well, thank you so much. You've been a wonderful panel. I believe we have no time left. So thank you for participating, and thank you, Verta, for the opportunity to have this conversation.
Thank you so much.
Thank you.
Thank you.